in terms of the RNA transcriptomic subclass, I don't know if this is working. Is there any information in terms of whether the aggressive ones, T cell lymphomas or B cell, with the new platforms, RNA-seq, or the older, and also a comment in terms of the immune checkpoint molecules and chemokine signaling? Is there any subclassification at the molecular level that we know of?
I think those studies are certainly being done, but in our Sézary patients, they were the mutations, the driver mutations they had were all over the map, but they were in T cell signaling pathways, in oncogenes and tumor suppressors. But we didn't do profiling for RNA. Actually, we have done that and are trying to validate genes, but it's a lot of work, and there's a lot of disease heterogeneity.
Did publish like a nice, pretty large study in which they divided their CTCL patients into 3 groups, and it correlated very well with prognosis. I don't recall exactly the details, but for instance, folliculotropic MF was in group 2. So we know that certain subtypes, they do have a different profile. So in terms of driving chromosomal defects, as we mentioned, there is nothing that we can pinpoint now. We know that in average, if you do CGH or like a platform sequencing of those cases with whole exome sequencing, they have an average of like 6 or 7 possible important mutations. Most of those cases. There was a study done from the Yale group. We did a study of about 40 cases that's about to be published at Nature Genetics. Madeline's, you have your data coming out. So yeah, Stanford, so everybody's coming up with data that, but we still don't know what's the long-term impact of all these exome sequencing.
Yeah, I forgot. Kupper's group in Harvard looked at RNA expression in skin biopsies and found 3 groups. And one of the groups was with more severe or aggressive lymphoma. And Ivan Litkov in Canada has been reproducing this work with other sets of patients, including our own, but we don't know yet.
And then one last question in terms of immunotherapy clinical trials that are coming up. You mentioned PD-1 expression. Are they responding? Are there clinical trials that are coming up in immunotherapy?
There are clinical trials. I think it's mixed so far. But
I just know of the Stanford trial that is going on. There are 2 patients who've been treated. They had partial responses and then progressed, but that is really preliminary and probably shouldn't even been said.
You were talking about a new classification system, because I can tell you as a practicing pathologist, and we've had a few cases on our service, where something is essentially biologically benign, but we're compelled to call it a lymphoma. Like you're talking about the small, medium, pleomorphic T-cell lymphoma. The variant that is solitary and occurs on facial skin is essentially benign, whatever you want to call it. Is the new classification system hopefully going to address some of these? And many of the entities you discussed today, they have such a good survival that I essentially consider them benign. I realize there's local recurrence, but systemic dissemination almost never occurs. What do I tell the clinicians, and how will the new classification help me to address that with the clinicians?
The small to medium pleomorphics are something we never saw, and now we're seeing about 2 a month. And the important thing, I think, is that they've been pulled out of peripheral T-cell NOS, which is a death sentence, and the small to medium, call them whatever you want, they've come out as an indolent group, so we can inject steroids in them.
What I do in these cases, I call them that, but then I have a very long, it's a very long phone call with the clinician. I say, I'm going to call this a lymphoma, but it's completely benign. Don't worry about it. It is a 5-year, 100% survival. It's sort of, you know what I'm saying.
Yeah. I don't call them lymphomas. I call them, but I make a note that many people would call this lesional lymphoma, in my experience, as long as it's a single lesion. This is a proliferative, like clonal proliferation, but of some people say of uncertain biology, but we know that's a certain benign biology. unless it's the tip of the iceberg and it's the first lesion of multiple lesions. If you have multiple lesions, all bets are off.
I called it the solitary lymphomatous papule. We published some in JAD. They always do well, even if they get chemo sometimes by the lymphoma people. They do well.
I know there are pathologists, not at Memorial, but, and not you, but in the city who share the same idea and will not call them lymphomas for that reason. But I'll be the devil's advocate, I guess, because I'm at Memorial, and say, just because something's lymphoma doesn't mean it has to be aggressive. And there are a lot of systemic B-cell lymphomas, like marginal zones, that they will just watch until a patient is symptomatic. So being indolent doesn't mean it's not lymphoma.
Yeah, but I mean, what's lymphoma? I mean, this is it's a philosophical question. And I mean, again, I think we do a disservice to our patients when we call something lymphoma that we know with complete certainty that they're going to do fine.
My issue is what do I tell the clinicians?
Yeah,
That's really the problem.
yeah. I mean,
You have to explain it to them so they can then explain it to their patients.
From the clinician's point of view, I get back this description about 4 pages of all these markers, and I don't know what they all mean or why you even did them, because you don't tell us what they are. You know, they're just CD something.
any other questions? Lunchtime. Thank you.